Good afternoon and welcome to Webinar Wednesday in this our 9th year of offering up-to-date and informative webinars to the HTM industry. Today we are joined by Sodexo Healthcare's Directors of Capital Planning, Scott Skinner and Morgan Ayres-Comage. Webinar Wednesday would like to thank our sponsor, Sodexo Healthcare. At Sodexo Healthcare, they build trusted partnerships with health systems to support quality care delivery. As part of their mission, Sodexo HTM helps improve patient outcomes through integrated technologies and operational efficiencies with flexible solutions to meet your needs. For more information, visit us.sodexo.com/HTM. Just a reminder that TechNation is headed to our Spring MD Expo at the Woodlands Waterway Marriott Hotel and Convention Center in Houston, Texas, from April the 11th to the 13th. Join us for 3 days of education, networking, and the latest advances in medical technology products and services. Registration is open, so for more details, please visit mdexposhow.com. Today's webinar is eligible for 1 CE credit from the ACI, and you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 CE credit, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. Okay, let's kick off today's webinar by giving away one of our Webinar Wednesday t-shirts to the attendee that can tell me the answer to the following trivia question. February is American Heart Month. What color does the American Heart Association encourage people to wear during this time? Answer now using the questions feature on your dashboard, and I'll reveal the answer at the end of the webinar. We'll wrap up today's presentation with a live Q&A, so please submit your questions anytime using the questions feature on the webinar dashboard. As I mentioned earlier, our presenters today are Scott Skinner and Morgan Ayres-Comage, and they will be discussing capital equipment planning in challenging financial times. So Scott, you may begin whenever you're ready.
Hi, everybody. Good afternoon. I'm happy to be here. I know Scott is too, but just want to give you a little bit of bio on myself. I'm a co-director in capital planning at Sodexo, which you all know. Formerly, I was at Aramark in various capital planning capacities with different health systems across the country. I've got a degree in finance and got a master's in healthcare administration at NUSC. And I'm currently residing in Virginia Beach, Virginia. It's not too beachy right now, but it's a nice place.
Thanks, Morgan. And I'm Scott Skinner, also a Director of Capital Planning with Sodexo HTM, coming to you from Kentucky, just south of Louisville today. Really appreciate everybody on the webinar. My background is more so with HTM operations, overseeing fairly large HTM operations and also clinical equipment replacement planning within a fairly large multi-hospital system. Joined Sodexo about a year ago. So we know that many hospitals right now are experiencing some very unique financial times. Our patient volumes are below plan at many organizations. Inflation has greatly impacted expenses, especially with supplies and with clinical staffing. So all that is resulting in operating margins being challenged, again, at many hospitals across the country. And ultimately, that's resulting in a scarcity of capital in many situations. So we know that, or believe certainly, that capital replacement planning is an important thing at any time, but especially so right now with the capital scarcity that is going on. So this is our agenda today. We're going to quickly review sort of a history of capital planning methods and talk about some of the prior methodologies and the limitations of those. We're going to talk about the Sodexo CRP, or capital replacement planning methodology, that we've developed that we think builds upon and improves some of the historical methods. We've got an example, or a theoretical example, of a hospital CRP and how it's actually resulted in scoring and prioritization for a theoretical facility. We'll talk about the impacts of the current fiscal environment and things we might do as HTM leaders at this particular time. And then lastly, we've got some time at the end to summarize, and then, like Linda said, have some live Q&A. So we look forward to hopefully interacting with some of you later in the presentation. So let's talk a little bit about the history of capital planning. And there's sort of several different perspectives that you can approach capital planning through. One is certainly that of the manufacturer. A manufacturer certainly has a product life cycle with its devices. It introduces things to the market. Eventually, they're going to come off the market, and they're going to look to sell the next version of product. Along the way, parts and service will become unavailable for most technologies at some point later in the life cycle. So that's one perspective. Another perspective is more so from the finance side. So looking at things from an expected useful life of how long an asset should last us, as well as looking at things from a book value standpoint. And last but not least is our clinical stakeholders. We know that our providers, our nurses, our clinicians are always looking at technology to see if it can solve new and evolving problems with patient care. There are always things going on that might enhance safety or effectiveness for our patients, and that is certainly a very important element. But we do believe that sometimes if you just focus on these perspectives alone, you may not achieve the appropriate results with the capital planning process. Now, most of us in HTM have reached points with a device where we say, how much do we put into something before we stop the bleeding and replace it? And this little graph is almost an urban legend that's out there that actually came out from the US Army in the early 90s. And you can see here on the x-axis is the percent of useful life remaining of an asset. And the Army actually suggested thresholds for what maintenance expenditure limits, if they are reached, that something should no longer receive repairs and it should be considered for replacement. So those maintenance expenditure limits are there on the y-axis, the left-hand side, and those are percentages of the original cost of the item. Now, this was picked up by ASHE and published in the mid-90s in a document that they put out as well. But here's an example in real life of what this could result in if we just focus on the maintenance expenditure limits. So most hospitals depreciate items using straight line depreciation. So in this example, we've got an item with a 10-year expected useful life. It cost $20,000 originally, and every year it loses $2,000 of its book value. And then below the blue line there, you can see the maintenance expenditure limit in red. And I guess the challenge with the MEL model is that at most points along the line here, there's quite a bit of book value still remaining on the device when the expenditure threshold is reached. So this is something to consider certainly, but maybe not necessarily the end-all, do-all. Now we want to pay homage a little bit to some of the prior capital replacement planning methodologies that have been out there, and this is not an exhaustive list. This just happens to be the ones that we're aware of. Larry Finico, who many of us know is a thought leader in HTM, came out with a publication in the early 90s that looked at multiple criteria for prioritizing equipment for replacement. Taylor and Jackson in the early 2000s, and then our own Dr. Bensing Wang in 2009. So again, this isn't necessarily an exhaustive list. I'm sure there are more out there that we're not aware of, but what our work does at Sodexo is take some of these prior methods, builds upon it, and improves it. And I'm going to turn it over to Morgan to describe the current methodology that we do use.
Hey, thank you, Scott. So, at Sodexo, we've got this capital replacement planning method, but before in the journey of coming up with how we would evaluate equipment, we wanted to focus and identify 4 main objectives. One being patient care. And I think that's probably across everybody's primary objective. The next one was our desire to be objective. We have to rely on data, not opinions. We want to sort of remove that political noise, right? And then another one of our objectives was providing some sort of flexibility. We know that standardization when evaluating these assets is important, But we also know that every single organization we deal with is different, and we believe providing some sort of flexibility for them to customize their replacement method is something that we also wanted to add to our objective list. And fourth, we always seek opportunities to improve this evaluation method. It's certainly not everything to everybody, but I will say that every time we do another plan, we learn something else and we find areas for improvement. So next slide, please. So we came up with this multivariate approach, and what we have here is we decided to create 4 different buckets of variables. You can see these buckets on your screen. We're looking at clinical impact, safety, condition, and supportability. All of those puzzle pieces sort of coming together to get the full picture of the technical health of the asset. I mentioned in the previous slide flexibility as an objective of ours. This is sort of where we put in this flexibility. In those puzzle pieces, you see percentages. And we believe this is our standard weighting for each of these buckets, clinical impact being 20%, condition being 20%, supportability being 30%, and safety being 30%. But we always engage the client in hopes and make sure that they are on board with our weighted percentages. But we certainly give them the opportunity to say, you know what, maybe we want to increase our safety bucket to be more than our condition, and we adjust accordingly. But it certainly is an engaged effort between us and our clients. Next slide, please. So what this slide and the next slide you will see, these are the buckets broken down into those individual variables that I was just mentioning. So we've got a clinical impact and safety breakdown. We've got clinical impact, which has 2 variables that we currently use, which is mission critical and patient impact. Remember that bucket's weighted at 20%. In each of these variables, we have weighted underneath at 50%. The mission critical is really important to us. We look for engagement from the organization. We're looking for mission essential equipment that has been identified by staff and administrative leaders. Doesn't always have to be something that's associated with any sort of service level agreements. It's just what the hospital believes is mission essential. Next is the patient impact. So this is a score, an internal score we developed that's based on functional and physical risk and the breadth of impact when failure does occur. This safety bucket, weighted 30% pretty heavily. We've got recalls, patient incidents, and cybersecurity. So we're looking at the count of all applicable recalls on a specific asset. You're looking at patient incidents, count of all applicable patient incidents to that active asset. And then cybersecurity. You know, we're lucky, we've got a phenomenal cybersecurity program in-house, and they risk score the asset. And so we get this sort of risk ranking for clients that have the cybersecurity program. But that doesn't mean you have to have that. I just want to state there are opportunities in the cybersecurity bucket. If you've got access to just the operating systems and whether they're out of date, you know, that is absolutely something you should use and score, even though you may not have a massive risk cybersecurity program. Next slide, please. Here we're looking at the condition and supportability buckets. I think condition is like a universal language between everybody. It's talking about age, it's talking about how it looks, the physical condition. We use relative age here, and we weighted it 30%, and that's compared to useful life. We look at reliability data, which of course is very important. We weight it 40% underneath that 20% umbrella for condition. And then the physical condition. And we're lucky enough to have some fantastic people on the ground that every time they touch a piece of equipment, they are able to score its physical condition and have it recorded. Next, supportability. This should be a bucket near and dear to everybody's heart. This is the magic, right? This is that subject matter expertise that I personally believe a lot of the administration needs to know. You know, is this supportable anymore? So we look at parts and service availability. We look at it on a high, medium, and low scale, both of them. We take a lot of input from the field experts to develop these scores. Of course, we do not leave out end-of-life documentation, but we probably all know end-of-life documentation is an end-all be-all. So we don't want to leave it out, but we certainly, you can see that it's ranked at 10%, where you can look at parts and serviceability. We currently have it scored at 30%. Lastly, we take a quick look at service costs compared to the similar equipment, either at that site or across the country. All right, next slide. So all of that variable conversation and weighting, etc. Why did we go into that? You may not have all of those data points, but if you have 4 of those data points, if you've got 5 of those data points, it's better than 1. It's better to look at a multitude of variables and not just rely heavily on, let's say, age or end of life, because you really could impact or skew or recommend a capital spending that may not be necessary. So, next slide. So now, this is like the math behind it. We score each of those variables in each of those buckets on a 10-point scale, 10 being the most severe. And then we apply the weights, just like we talked about, the 10% for end of life, the 30% for parts and service availability, and then we add it all together and we come up with the hour, what we call the equipment replacement priority score. It's not fancy math, it's basic, but it comes, we do get a very nice, relatable score for us to compare each and every single asset, capital asset. Next slide, please. Okay, so we do all of that, we gather as much information as we possibly can, and now let's take a look at the result, or how we can give the information, how we can make it digestible. So here is a sample health system. So before we dig into the actual chart, you know, envision you have a 200 licensed bed, you got 8 outlying clinics, it's about 3,800 assets. Clearly, you are not looking at 3,800 assets on the screen. It's truncated, but we wanted to show you the sort of scale, as you can see in the heat map over there, red being, oh my goodness, that feels like a priority replacement, green showing, oh, maybe later, all right? So if you look at the chart, we've got needed information, asset numbers, equipment categories, device descriptions, there's your departments. And then you see in those yellow sections, oh, there's our scores that you just calculated with all your percentages. Then there's our output in the equipment replacement priority score. And then you've got a cumulative budget total. And then here's suggested replacement timing. This is how we do it. This is how we display the data. And this has all of the nitty-gritty details. So this is where you've got somebody that wants to dive in and sort of dig through the data. That's not for everybody, right? But I do want to bring your eyes to the priority replacement section, that red section. You know, that's what we're here for. We're here with this fiscal environment, the constraints that we have. We're really here to help identify those priority replacements, right? That's what people are asking for our help on. All right, the next slide. So that bunch of data on the previous slide can be summarized fairly quickly, right? So we display a chart. This is high level. This could quickly, easily be given to administration just to start a conversation. You can see priority replacement, which was those red items we were looking at, which clearly were more in number. You only saw about 6, you didn't see 91. But look, we've identified in this sample health system 91 pieces of equipment worth about $6.6 million that need to be focused on our suggestion for replacement. I want to say we all know that every 91 pieces in priority replacement is likely not going to get replaced. We also know the reality behind things that are in other people's priority lists that aren't falling in our technical health priority replacement bucket. So we often see some items in years 2 and 3 may get moved by administration because they know more about strategic planning that may end up in that priority replacement bucket. But remember, this technical health assessment is just your starting point, right? It is a place to start and then build on top of, but it allows, if you need to dig into more data, you can dive in and you can go and look at the heat map and you can sort of see, what's driving replacements. Where were those concerns? Oh, this was a mission critical device and we can't get parts for it anymore. Well, that's why it really should be considered a priority replacement. All right, next slide. So what we're looking at is that same priority replacement group of equipment, but we're looking at it by department. It's not that this is hard to understand, but breaking things down, that chart I originally showed you with the heat map, it can be too much data for people to digest. So you take the opportunity and you break it down to have by department and share it with department leaders. I will say I have oftentimes had training sessions with groups of departments, talking to them about our method and the results that we've delivered to a hospital. And we go through, I get some of the most engaged conversations when we start breaking things down by department. And I show, oh, this is what's in the OR, and then we dive a little bit deeper. They ask a great question, and I say, oh, wait, let's go look. Let me show you how you can see what pieces of equipment I'm talking about. Oh, remember, these you can't support anymore. There's no service availability on it, etc. So this is a conversation starter with your department leaders, with your administration. But I will tell you, this is where my best conversations come out of. All right, next slide. So you've done all this work with collecting all this data, you've evaluated the data, and you've told people you've got 91 pieces of equipment that you should think about replacing this year. But you have something else. You can consolidate that information, and you can consolidate it by OEM, and then you can very quickly take a look at which OEMs you are most invested in. I'm sure the top 5 are no surprise to people at the organization, but I will say it can be used as a great way to leverage for negotiation, for supply chain. It's almost like a cheat sheet. So if you ever had the opportunity and you did all of this and you just wanted to strike up a conversation with supply chain, maybe this would help. Maybe you could show them, look, we're looking to replace almost $2 million worth of Philips equipment for priority replacement. But look, man, over several years, we could possibly be spending $21 million. But remember, it's a cheat sheet. It's a nice way to slice the data and to share with others in your organization. Next slide, please. All right, this is Scott. I'm going to hand it back over to Scott.
Thanks, Morgan. And we're going to come back a little bit to where we started with the current financial situation and some potential responses of healthcare organizations to the constraints that we're dealing with. So there's a number of them here to talk through, and these are in no particular order, but The first one is to certainly continue as planned. There are some hospitals out there that enter these financial times with decent amount of cash reserves on hand and are a little bit more able to stomach some of the challenges that are going on in the environment. Or it may be the situation that a hospital already committed to certain purchases and made contractual agreements and has to continue. Or there may be risk out there that are felt that they're significant enough that even though it's painful to dig into the cash reserves to fund them from a capital standpoint, it may still be the right thing to do. Now, the approach that we're seeing quite a bit right now is some sort of version of capital rationing. And this can come about in more of a freeze or a frost. So there may be hospitals out there that say, you know, we're going to delay most of our capital purchases. Let's hold off for the next 6 months, most of our major capital purchases, and then we'll reassess and maybe see where things might be. There may be other hospitals that decide to proactively break up or phase purchases where it makes sense clinically to do that, or where it's possible to do that. An example might be an organization that's multi-hospital that was going to replace all of a category across the entire system all at the same time. And maybe we need to go back and look at phasing that in and maybe replacing 1 or 2 hospitals at a time, you know, and phase that over a number of years. We're also seeing quite a few hospitals develop new, more stringent governance models around capital. So the capital committee kind of amps up a little bit and gets on steroids because there's fewer things that can be funded with a limited amount of capital. There might be additional rigor and structure, additional scrutiny on capital requests as they come in. Now, it sort of goes without saying that if we do some of these things, it may create additional risk for the organization. Like if we say we're only going to be in an emergency replacement mode only, that could mean we're going to delay some of the proactive replacement, and we may have some risk build up in that situation. But we definitely tend to suggest to folks that if nothing else, focus on the mission critical items, the things that are really key to the organization continuing to operate and provide normal throughput of patients throughout the care process. Another option is looking at taking the existing capital that you have and trying to make it a little bit more efficient. So this may involve actually spending some money to try to gain some efficiency. But we all know that with certain categories of portable medical equipment, much of it can sit around idle and non-productive throughout large portions of its lifespan. You know, things that are highly portable that there's large fleets of, like infusion pumps and DVT pumps, many times can be misallocated around the hospital, misallocated around departments. And some organizations have HTM or supply chain or some other department that is actively managing certain amounts of those. So they may do some cleaning and logistics. They may pre-stage equipment out on par levels or deliver equipment as needed. And that might be a way to, again, use that existing capital that you have, but maybe use it a little bit more efficiently and perhaps extend the life of it. Now, some other more creative approaches to the capital situation that we're in. There is sometimes the option to operationalize the expense. Instead of having a capital expense, we can go out and go through some creative means to acquire capital equipment. Rental may be an option in some situations. For example, if we have some equipment that we say, you know, we plan on replacing this in 6 months, we don't have the money right now, let's maybe look at renting that short term for the next 6 months as a bridge to capital. And when that capital does come available, then we'll actually consummate the purchase and truly replace the equipment that's there. Placement agreements are another option. We see times where some equipment almost comes in as a norm under a placement agreement. Probably DVT pumps and breast pumps are some of the examples that fall into that category. And then you've got even more creative things with arranging some sort of like a cost per case or cost per reportable to gain access to capital equipment. We're seeing this more and more, especially with like very high-end lab equipment that involves automation. So instead of outright purchasing multi-million dollars of automated lab equipment, you may arrange with a supplier to do a per test basis. So every test that's completed on a patient, there's a certain fee that's paid, and that fee covers everything. It covers the equipment, the software, the ongoing service, and the reagents that were used to obtain that test. Another example we're seeing a little bit right now is with robotics. So some companies are moving to a model where the robots are coming in and being paid for on a per surgical case basis. Now, obviously, the suppliers are looking for certain minimum case numbers to be met there, but for something that can be multi-millions of dollars to invest in, that can be one other creative option. Now, these creative options certainly may have a higher cost of ownership in the long run. Generally, as things become a little bit more convenient and you're taking some of the risk and asking suppliers to bear that risk, there's generally a cost sometimes for that. But on the other hand, this can be a way to kind of protect against obsolescence. So if you do a deal to bring a surgical robot in and it's a 3-year contract, and at the end of those 3 years, the existing device goes away and you can go do a new contract to bring the next latest and greatest version in of the robot. It's essentially like a car leasing model, right? You lease the car, you do so many miles per year, you turn it back in once the lease is done, and then you've got the choice to re-up and you get a brand new car. Again, it may be convenient, but sometimes you have to do the math carefully to make sure you're not paying more of a premium than what you thought. Now, fundraising is not something that we think a lot about in HTM, but I have seen it be applicable. There are many hospitals out there that have an internal foundation, or there may be charities in the community that are actively wanting to support certain causes. I worked at a hospital system where there was a charity in the community really interested in children's initiatives. So we would sit down from time to time with the philanthropy folks inside the hospital and say, here are the things that we've got on the capital list. Do we want to go to the charities and make a request for any of these things? Does it make sense to do that? Also, the debt market is another creative option. Certain hospitals have access to government issued bonds as a form of debt, and then there's also traditional loans and financing. Although I would say this is probably more common with major medical equipment, heavy iron, LINAC type of things, or it may be associated with equipment that's in a larger construction project. So let's say we're going to add a 500-bed tower to the hospital, and we're going to finance that entire project with bonds, and it's going to be everything, the bricks and mortar, the minor equipment, the major equipment, that sort of thing. Now, lastly on here, vendor deals. If there's a scarcity of capital right now, which means that maybe not a lot of hospitals are out there doing deals, that may be able to help get some attention for creative arrangements with some of the suppliers. Maybe coming up with creative payment terms could be one example. We do a contract and we get access to the equipment immediately, and we don't have to pay for that equipment until 12 months from now. Now, many hospitals would say, well, that's still got to go on the balance sheet as a liability from the time that we consummate that contract. But at least from a cash flow standpoint, it could certainly delay the amount of time that the cash has to leave the organization. Certainly, these things can be hit or miss depending on where the supplier is in the competitive nature of a project and the timing. Is this close to the end of a quarter or the end of a fiscal year for the supplier? And they're a little bit more likely to be creative with some of their terms. And then demo and recertified equipment. This may be a consideration for some hospitals with some categories of equipment. Here again, the availability can be a little bit variable, maybe not something to rely upon, and it really depends on the organization on how much risk tolerance they might be willing to consider with this. Some of this equipment, if purchased directly from the OEM and it's been essentially remanufactured and certified as such, that might be viewed as lower risk compared to something that's bought from a third party. So again, that's something for the individual organizations to weigh and make decisions around. In reality, though, we realize that not any one of these solutions is going to be the end-all, do-all solution that gets a hospital through these times. It's likely that a combination of these different things will be utilized. And some of these might be just in the short term, and some might stick around for a while. For example, if the capital committee gets a little bit amped up and has more structure to it, that may be something that stands around in the long term, even as capital becomes a little bit more available. So you may be saying to yourselves, well, many of these things that you mentioned are really outside of HTM's direct control. What can I do? And this is a great example where HTM has a logical approach to so many things, and we can be a source of objective reason with some of this decision making in this very limited capital environment. Those of us who've been in HTM for a while know that there's always challenges with the inventory and maintaining the data quality in the inventory, but there is no worse situation to be in than to get a call from an administration at 4 o'clock on a Thursday and they say, hey, we need a list of all the high priority capital by tomorrow at noon. And you work on that furiously and try to correct some things, and you turn that in, and then you get some feedback that there are some problems with it, that some of the stakeholders notice that some of the data is incorrect. So again, we all know that inventory is a challenge, but maybe consider breaking up the idea of doing some quality control on the inventory. Every week, pick a small subset of the inventory to look at and do some quality review of, and decide if anything needs to be changed because some assets were copied and some of the old information made its way to the new assets, that sort of thing. Now, one really key recommendation we have is we understand that not everybody may have the time to go through a very large multivariate capital replacement planning process and develop a truly comprehensive list, but we do recommend thinking about maintaining at least a priority list, a high priority list. So you're probably already actively monitoring certain trends within your data and reporting those things to your EOC. You're probably also very aware of what's going on with some of your mission critical equipment. That's information that, if nothing else, try to feed that into the list of the highest priority items and have some sort of ongoing communication with administration about those. Hopefully proactively reaching out and saying, here's some risks and here's how that risk is moving around as we delay some of these capital replacements. Also, something we can be doing right now is definitely partnering with our clinical stakeholders to understand what challenges they're having with the technology, what trends are going on, and how that feedback needs to come back into our priority list and overall list and help shape the information that we're presenting. We always want to try to be in alignment to the extent possible with our clinical stakeholders. So a few other things we can be doing as HTM while we're in this capital environment. We can be helping with evaluating and selecting make models so that when the capital does eventually free up, we'll be ready to complete purchases. Some of these things take time. They involve RFPs or RFIs. They involve demos, maybe doing trials, site visits to other hospitals that are already using the technology, reference checking. A lot of these things can have a very long lead time, and they are something that we can be working on in the interim. Likewise, once we've reached the point of deciding on a make model, many of us are in hospitals where the legal process is a potentially lengthy process that takes months. So that's also something that can be worked on. And even if we're not ready to sign a contract and issue a PO that we're ready to move forward now, maybe it makes sense to go ahead and develop a contract that says when we do get ready to purchase, let's go ahead and agree upon the pricing and the terms and conditions so we can be ready to move a lot quicker if the availability of capital rapidly changes. Many of us are in environments where IT risk assessments are quite involved at this point. So this is also something that we can be working on depending on the timing. If we know that it's going to be 2 years before we invest in a capital replacement, it may make sense to maybe just do a high-level risk assessment. And as we get closer to the actual transaction, complete the full risk assessment, because a lot can change over a couple years or whatever that time horizon might be. And then lastly, there are, with a lot of these projects now, lots of moving parts with planning that needs to be done with clinicians and with IT, and that's something else we can be focusing on. So with that, we've got some conclusions here to quickly go over, and I'm going to turn it back to Morgan.
Hey. Okay, so we have to talk about limitations and maybe what the future can bring. Some of those continuous improvement efforts. We know for sure there are limitations specifically to our process, but just to our data in general. We know that politics is a bit unavoidable. Of course, as HTM and certainly us as an ISO, we try to stay out of that stuff. That's why we're here, because we can provide an unbiased point of view, but it still happens, right? So that's one limitation. We also have to be very cognizant that what we're evaluating, our technical health assessment of these pieces of equipment, it's only part of the story. It doesn't include infrastructure. It doesn't include capital investments. It certainly does not include strategic planning. Now, I do believe, though, this is the baseline to it. So you can layer in that strategic planning, those strategic planning initiatives, or your administration can layer it in. It's a place to start and a place to add to. Everybody feels the pain of all of this data and the data points you have to maintain. This process is certainly heavily reliant on accurate data. So it's no surprise, garbage in, garbage out. I do want to state though, just because you may not have the most fantastic data, that doesn't mean you shouldn't start putting together capital replacement planning with a multivariate approach. There's always room for improvement. So you do it once, and then you do it again, and another 6 months. But by doing it, it kind of helps identify some of those data points that you should focus on more. And it's only going to help you improve in your data collection. Last but not least, of course, when you take a snapshot of your inventory, it's at one point in time. It's not alive, right? And we know that items and assets are getting added and removed all day long. So that is certainly a limitation, that this is a snapshot, a point in time that you're looking at, and soon enough, that inventory list will change and you will be back at it. Maybe it's quarterly, maybe it's every 6 months, maybe it's once a year or every other year. But it is only a starting point. From that point in time, you export your information. So let's talk about the fun stuff, what this can be, where it can go. Maybe there's an opportunity in your organization that you've got access to utilization information. Maybe you can partner with your radiology director who may have some utilization information you can weave into the plan. I think that is a beautiful next step, certainly for evaluating some of those high dollar big iron pieces. Next, maybe there's a potential to integrate, that heat map into a CapEx system. Well, if you know that this was a priority replacement, you can't get parts for it anymore, it's mission critical, and it was in the same spot where you could submit capital requests, I think that sounds pretty efficient. Another opportunity, reliability based on make and model. Sodexo is working on that with our new CMMS tool, and that is going to be paramount. Really understanding reliability based on that model and that OEM. Lastly, interactive data tools. So yes, we have this snapshot, but allowing somebody to come in and maybe do some scenario planning. What if we did this? Or what if our budget is only this? It just makes it more interactive, and that is another place that there's room for improvement and we're looking to go. Next slide, please. So, I'm biased working for an ISO. I love the fact that I'm not influenced by any OEM. It makes my job very neutral and feel like you can just present just the facts. This is the data that we have. This is the information we have. We also get the opportunity, certainly Scott and I being able to work with all of our clients across the country, we also get to share some of best practices. We get to share experiences, anecdotes from somebody on the East Coast to somebody on the West Coast. It's not only do we get lesson learned, but it provides for engaged conversations as well. And like we'd already talked about, we try to stay out of the institutional politics, and that is one of the things that we like to do and we can do as an independent service organization. All right, Scott, I think you're next.
Yeah, just quickly, we've got some lessons learned here. We're not going to cover all these because I know we want to have some time for a question here at the end, but hit on a few of these. Like Morgan has talked about, just because the data isn't perfect, don't let that hold you back in getting started. You have to start somewhere, right? And think about having some sort of process to continually evaluate the quality of your data and improve upon it. We didn't talk a lot about scope of the capital replacement planning, but that is an important thing to identify up front. You don't want to spend a lot of time on things that might be out of scope if someone else has already got that included in some sort of other plan. The other thing is involving the team. As this process goes on and there's an opportunity to gut check and get feedback from the team that's servicing this technology all day long, this is a way to get their feedback and get it literally in the hands of administration by incorporating that feedback. So very, very important process there. So just in overall conclusion, before we get to questions here, as you all can tell, we definitely believe that this is a way for HTM to continue to get itself out of the basement and operate at a more strategic level in most organizations. Very important opportunity to position us in things that are more than just in a support role, but driving decisions within the hospitals and facilities that we service. So I think we are valued many, many times for the objectiveness and the logical approach that we bring to things and help look at things in a very balanced way. So with that, we really appreciate the time today, and I believe we are going to turn it over to questions.
Thank you so much, Scott and Morgan. Yes, we've got quite a few questions that have come in. So the first one is, what suggestions do you have if there is no extra funding to try to tap into?
We did have some creative options that were listed there. I think, to me, if you can present leadership, present administration with some scenarios, we want to be, as HTM, we want to be solutions oriented, right? We want to be there to offer decisions to move upon and be part of solutions. So I think if we don't have access to capital of any type, then maybe we research some other of those creative options and maybe present that as we're having conversations with leadership.
Okay, and what about, as a biomed, how do we get a seat at the table during capital planning discussions? I mean, who might make those decisions on committee members?
Well, I'm not a biomed, but there's a big but there. I do think it's absolutely imperative that biomeds get the seat at the table. And we talked about them a little bit in the presentation. Anything, you all have some real subject matter expertise to give. You have really good data. And although you may not have a complete capital replacement plan, but if you have got that priority list that Scott was talking about, or just a couple of pieces of equipment that you all aren't going to be able to support next year, those are the tidbits of information that you need to start sharing. Of course, you need to find your stakeholders in the building. Who are those people that need to know those pieces of information? But I've always thought, you can talk to supply chain. Make sure supply chain knows where you are, who you are. Certainly finance. usually see those two departments as a seat at the table, radiology directors. But I definitely want to say, take some of that knowledge that you have, and if it's not in a capital plan, get it in sort of a succinct way to share it, and do that regularly, and keep people updated regularly with that priority list, or those pieces of equipment that you can't support anymore. That would be my 2 cents.
Okay, so during the method you discussed, how do you determine the key factors for each facility so that certain ones are weighted more heavily?
Well, we've developed our weightings based on our own experience, but that's where definitely Morgan was talking about customizing those weightings. We want to meet our hospitals where they're at, what's important to them. So really having that upfront conversation as you're going into the scoping of the plan and how the information should be presented, I think is important.
Yeah, and just a quick example, we talked about maybe an organization wanting to change the weight of a variable or a bucket. I have one particular, they didn't want to change anything. They wanted to add 2, which I thought was very interesting. They wanted to add a variable, a bucket, and they considered it clinical priority. So it was an opportunity for their organization to be a part of the equation. Yes, it became a little bit more subjective, but it had a percentage as well. So that was a very good experience. Now that was data to cultivate from those stakeholders and those departments that came up with their priority list. But if they identified something on as priority, remember we still use that 1 to 10 scale, it was just an additional variable. So I would say that actually turned out to be a fairly insightful plan, combining technical information with clinician needs.
Okay, that's great. Another question that's just come in is regarding reliability, what specific metrics do you use?
Our internal reliability is not done by me, I can tell you that much. Our program management team evaluates it, and for me, it's in our system already identified. I don't know, Scott, if you know how they actually do the math behind it. I know it's based on device description.
So we do look at mean time between failure, and we've assigned weightings to the different frequencies. So if something is less reliable versus more reliable, so that's how we approach it in general.
Okay, another question here is, how do you access patient incident data, and how do you determine validity for inclusion in your CRP?
So our CMMS is built with a work order category for patient incident related, obviously in a HIPAA compliant fashion. So that is information that we're actively capturing. When there is a patient incident that HTM is involved in investigating on something, an actual discrete work order event is created, and that is something we can go back later and access, look at not only the statistics of that, but examine the individual work order as well and see if there's anything to learn from that.
Okay, and leading on from that, what percentage of your clients actually access the CRP service?
So our services are included as our standard, part of our standard service solution. There are, I suppose, those clients that are few that, have a robust or dedicated capital planning function, and they want less assistance and less input. But the vast majority of our clients do leverage the information that we're developing and providing. It's really variable, of course, on how the clients want to interact with us. Some get extremely involved and want us to present the information to multiple department leaders and service line leaders within the organization. Other facilities, there's a central person that takes the information and they share it around within the organization, and they use it to base discussion and decision making off of. So it just really varies.
And it varies in frequency too. So sometimes, you know, we're engaged doing a capital plan, but it's every other year. And sometimes it's every year. And then sometimes it's quarterly or every 6 months. So.
Okay, great. Another one is how do you designate the scoring responsibility? Who does what to get this data entered, and how often is it updated?
Most of the data is coming from our CMMS tool. So the responsibility for making sure the device is right, et cetera, and input, that's going to be the field, our biomeds and our CEs in the field. Then there's some other parts that we do externally and we source externally, and that would be like parts and service availability. And so between Scott and I work on a project and he works on another. We don't necessarily divide and conquer individual variables. It's by project. I don't know if that answers his question. Scott?
Yeah, I don't really have anything to add, Morgan. I think that does a good job of describing it.
Mm-hmm. Okay.
Great. We've got time just for one more question. Is how do you deal with physician preference on EOL and vendor?
We don't. I mean, it's physician preference is not a variable in the model. Now, I gave you the example of a client where they said, we love all of this data, but we really do want some clinician input or department manager input. And we added another variable, and that being, you know, clinical priority. I will tell you, I did not drive those conversations with the clinicians. Our on-site staff did. And they gave them and their department managers the scale of 1 to 10 on how they would rank their equipment and their department by priority. And then that was weighted, I think it was weighted at 10% in in the clinical impact bucket. So then it turned around and it was weighted 20%.
Okay, that's great. Thank you so much. If you have any other questions, please feel free to email Morgan and Scott. Their email addresses are actually on the screen at the moment. So as we're coming up to our hour, I'd like to thank you both, Scott and Morgan, for your time and for a really great and informative presentation today. I'd like to encourage everyone to visit today's sponsor to learn more about the products they provide to the industry. So please visit us.sodexo.com/HTM. As promised, the answer to today's trivia question is red, so congratulations to our winner, Casey Stokes. Just a quick reminder, you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 CE credit from the ACI, and you'll be able to download the certificate directly from your computer once you've submitted the survey. If you have any questions, you can reach us at webinar@mdpublishing.com. We'll be back next week with another webinar, so please visit webinarwednesday.live for more details and complimentary registration. Thank you once again for your time today. Enjoy the rest of your day, and we'll see you again soon.